Thank you so much, sir, for the wonderful introduction. I'll just share my screen and is it seen, sir?
Yeah. Please go ahead.
Yeah. So yeah, my time starts. So I don't have any financial interest, but definitely have the finance interest of what Samresh has. So you have told it very perfectly what an anterior surgeon should do, the anterior vitrectomy. So definitely I cannot defeat Samresh in two things. One is his personality, looks, and definitely his grants and help from Alcon company. So we all know all these movies from the past. They've always said never poke anyone from the back. And if Samresh is planning to do something like this, definitely that's not something which I can win. It's like telling a corneal segment surgeon, showing him this and say, see the layers. Even if you mark out the layers, I'm definitely not going to know which layer is what. So coming over to the procedure, it is so simple when you do it anterior. The fear of the vitreous loss for any anterior segment is there. You just have to put some triamcinolone, make sure that you stain the vitreous properly, and always you will have some in the wound. There is no vitreous loss without it being in the wound. So always start from the section. So you can always do this vitrectomy only if you do the limbal approach. And then when you start going in, either with the 23 gauge or 20 gauge, do it near the iris. And then for vitrectomy, actually, they say that you can go below. There was a false misconception that the vitreous comes forward. But as long as you cut and aspirate, which I'm sure Samresh also will agree, the chances of vitreous coming forward is definitely very less. And you can even sweep through the main port, go all see the vitreous which is attached at the section. And also you can do the vitrectomy as well when you go through the anterior approach. I'm definitely sure reaching the anterior segment is going to be tough. In places where you have some remnant cortex or anything, it is also an easy approach because it is something similar to the bimanual aspiration that we do. So you can see that the remnant cortex and all which can be removed even anteriorly, and you can go little to the core of the vitrectomy base. You don't have to go too much back, and you definitely have to see what you cut. So I drive this kind of a red car with this machine is what I have. I'm definitely sure with Samresh's machine and his car which he uses, he will always get the 23 gauge vitrectomy. He should know that all of us don't get the 23 gauge vitrectomy for all these machines. So with the side port which we normally use, a 20 gauge will snugly fit. All of you must agree that you should have a snugly fit side port for the vitrectomy. And if at all you do a side port and make it a 20 gauge, you definitely have to suture the sclerotomy or put a trocar. So this is also where you have a PCR, you can do it at the iris plane, and then you can see that the PCR does not extend, which is something which they say there are chances of extending. And to also note that when you also place the IOL, and then if you want to wash the visco, you can actually go anteriorly behind, through the limbus behind the IOL. While washing the visco, you can also cut. And we have moved over from the micro incision cataract surgery to what Samresh is going to talk about, the multiple incision cataract surgery. And we all know that when you want to have after a vitreous loss, the first thing, this is done by a retinal surgeon, you can see the hypotony. This fear, if you get while doing trying to put a trocar or any port, is going to be definitely tough for an anterior segment surgeon. Let us all be sure of that. We are not posterior segment surgeons. And putting this amount after a hypotony, you will definitely make sure that you damage the retina on the other side, or do an optic nerve sheath fenestration while injecting the trocar. And not only one, then you decide your infusion port is there and you need another. So you make it multiple incisions. So when we don't have proper literature, finally it comes down to the crowd's choice.
I was the best because the crowd loved me. And the crowd, you win your freedom.
So there was a poll, audience poll, which was done in ASCRS, where they showed that 70% of them performed bimanual anterior vitrectomy. Samresh can actually have that 6% of the people who actually performed bimanual pars plana vitrectomy. And coming over to the complications, yes, this is the most important. When you go anteriorly, wow, iris tissue injury. I think there is nothing more to add to it. And when you go pars plana, there you go, the retinal tear, the detachment, the hypotony, the effusion, the hemorrhage for the endophthalmitis. I'm sure that all these complications are possible even in anterior vitrectomy. But when you have to choose for the patient's benefit, the risk of anti-vitrectomy through pars plana, when it is increasing, why do you as a surgeon want to give an increased risk of problem to the patient? And sometimes I'll say, always fight me anteriorly, never go behind my back. Because if I have to teach you a lesson, I will go and whatever means to teach you a lesson in the proper way. So thank you, Dr. Chitra Madam. Thank you, AIOS, for giving me this opportunity.